So I'm going to do my best and try and talk and chew gum at the same time. All right. So my name is Deirdre Calvert. I do go by Dee. And I also worked at a methadone clinic. I love these pictures. So I worked at a methadone clinic in 1997 to 2000. And so I just want to show you what was going on in 1997. Number one, I was smoking. Okay. I don't know if any of you know me, but I've also run 40 marathons since then. I've quit smoking. And I put this one up here because I was leaving the methadone clinic and going to work at Cambridge Health Alliance. And so I was transferring those jobs. I was getting my new ID. So that's me in 2000. But we also had the invention of our flip phones. Let me see if this is where I need my notes so I can be funny. So we had flip phones, we had the Titanic, Princess Di was still alive. I think that was her revenge dress. But and what I can tell you right now is that if you took me now 30 years later and put me in a methadone clinic, it'd be exactly the same. I'd be able to pretty much do my job exactly the same way because nothing has changed in the methadone clinics. And we have such advancements in addiction medicine. We have fentanyl, we have a poison drug supply, we have all of these changes, and yet many of these rules have stayed the same. All right, so that's just kind of going over where we were. All right, so this is where I actually need my notes. So the federal regulations, this is, I'm so sorry, I need to like read my notes. And the little thing keeps popping up. The federal regulations have failed to advance with our understanding of opioid use disorder, with opioid use disorder treatment. As we know, this has much to do with the racist history of the war on drugs, the stigmatization and marginalization of those who use drugs. Since the first regulation of methadone was implemented in 1972, people receiving and providing methadone have been under scrutiny. In the time since, little about the regulatory scheme has changed. COVID ushered in some of the greatest changes in the clinical flexibility for methadone prescribing at the federal level. In 2022, federal rules were proposed to expand access to mobile and medication units, and in 2023, an updated take-home guidance was released. In 2022, BSAS reviewed the OTP regulations and amended to fully align with the federal standards and guidance. And so, thank you. I have to stop and say one of the things I wanted to say at the beginning when I took over this job as the BSAS director, I'm a clinician, a social work clinician, has worked in almost every level of care. There's two things I wanted to do. I want to change methadone in the way that we deliver it, and I want to change Section 35. So if you want to go to that conference later, we'll let you know. So the fact that we're federally aligning, that was huge, right? So to move a system that gives individuals more autonomy and empowers clinicians to utilize their best clinical judgment. Yeah. So while OTP regulations and operations have mostly stayed the same, the overdose crisis has and substance use disorders have evolved. In 2019, only about 400,000 people with OUDs received methadone in the US, even though approximately 1.6 million residents are diagnosed with OUD. Similarly, Massachusetts has 55 community-based OTPs serving 24,000 people, but there are an estimated 96,000 people in Massachusetts with OUD. The overdose rate continues to evolve. Rates of opioid overdose deaths have increased from 375 deaths in 2000, when I was running the methadone clinic, to 2,357 in 2022. Fentanyl is present in over 90% of our overdose deaths, and disparities continue among Black, Latinx, and American Indian populations. So OTPs were also created, like almost all of the BSAS license programs, for white, middle-class, middle-aged men, right? And so they do not conform to what we need today in our society. More and more, our current system is not meeting those needs of people with OUD and our people, the communities of color, who are disproportionately impacted by OUD. So recent federal progress. Thankfully, there's been huge progress due to COVID. And what I'd like to do is start by thanking every provider in this room, every provider who is working hard, who worked hard during COVID and is working hard to meet the needs of all of our patients. So prior to COVID, OTP regulations required daily in-person medicating under an individual unless an individual met certain criteria. In 2020, a SAMHSA waiver allowed for the more flexible take-home policies, telehealth counseling, telehealth induction of buprenorphine and naltrexone. And Massachusetts embraced the flexibilities that were possible and encouraged OTPs to give as many take-homes as possible to reach each patient. COVID was not great. It was awful. But one of the things it really gave us was this pilot, this opportunity within Massachusetts to kind of do what we always wanted to do, right? So it really gave us this flexibility, allowed for creativity. We utilized home delivery of medications. We did delivery of medications, dosing for homebound, curbside dosing, chain of custody. So during the pandemics, OTPs were allowed to provide patients with up to 14 to 28 days of take-homes based on the discretion of the OTP medical director. And let me tell you, if we found out a medical director was not giving out take-homes, Jen Babbage would get on the phone and she would call them and say, can we talk to you about why this person's not getting take-homes, right? So we really did take that approach. In order to ease the transition for OTPs, we also implemented BSAS, implemented the reimbursement process for contracted OTPs for lock boxes, medication bottles, caps, labels, cell phones, data plans. We paid for anything that might have gotten in the way of somebody getting their take-homes. We wanted to make sure that not only they had their cell phone data plans, that they could keep in contact and have those telehealth appointments. And we provided the whole OTP system with free naloxone. We know that the uptake of these flexibilities were well received by patients and staff. Prior to COVID, only 15.6% of all OTP patients received take-homes. At the height of the public health emergency, we were giving 52% of OTP patients take-homes. And right now we've settled into about 44% of all OTP patients are getting at least between 1 day and 28 days of take-homes, which is just phenomenal. So to examine the trends in OTP enrollments and take-home medications during dispensing during the COVID-19 pandemic, we developed and distributed a brief survey. I'm sure you got tons of them from us for all the community-based OTPs administered from mid-January 2021 to February 2021. And our survey primarily collected information on monthly enrollment numbers, dosing-related outcomes for all patients from January 2020 to December 2020. Yeah, so that full 12 months. The survey compared outcomes for individuals who were approved to receive take-homes prior to COVID-19, individuals who only received in-person dosing, individuals who only received take-homes as well as a result of the blanket take-homes, and take-homes that were approved based on COVID flexibilities. 34 of the 55, I don't think we have 55 then though, we have maybe 45. 34 OTPs were surveyed. The results of the surveys helped us build our case to align the state and federal flexibilities. So what did we find out? We found out 57% reported better patient engagement and participation. We have 51% reported patients having improved access to OTP services. We had 60% reported increased flexibility in scheduling of OTP staff. We had 2,000 unique individuals get on methadone clinics during COVID. Like, that's amazing, and that's because of the flexibilities. There was also a really low revocation of methadone. I think it was between 0.7 and 9% of revocation. But we had no significant increases in critical incident reports. And based on all of these findings, we had an overall success of take-home doses in Massachusetts. We strongly recommended the continuation of the COVID-19 flexibilities post-pandemic, increasing our regulatory reliance on individual treatment plans as determined by the patient's medical providers. So in April 2023, SAMHSA released the updated take-home guidance, including new eligibility criteria that went into effect at the end of the COVID public health emergency. Massachusetts concurred with the updated guidance and aligned with all federal regulations. I have to say we pushed for farther. We did. We really pushed for them to go farther, but this was as much as we could get. So patients are now eligible for up to 7 unsupervised take-home doses of methadone from 0 to 14 days in treatment, up to 14 take-homes in the first 15 to 30 days, and up to 28 take-homes in the first 31 days. This means that patients can receive take-homes sooner in treatment and more than they ever had been able to before, which is fantastic. In all instances, it is with the clinical judgment of the OTP practitioner to determine the actual number of doses. So, recent state progress. So, state data has helped show us the successes that we've had in expanding access in Massachusetts. So, this is how I knew that there was 55, by the way. So I did read my notes. So we have Massachusetts is divided into 6 regions for licensing purposes, and you can see that the OTPs are relatively spread out throughout the state, but we definitely have methadone deserts. We also don't have great transportation in our western part of the state. So when clinics are staying open on Sundays and requiring people to come in on Sundays, and you don't have public transportation, what are these folks supposed to do? We're putting people at risk. So we have 55 community-based OTPs that serve about 24,000 patients. Additionally, there's 39 acute treatment providers that provide inpatient withdrawal management. There is also OTP certified programs that are also certified programs. Massachusetts requires all inpatient withdrawal management programs to provide methadone as an option. There are 3 operational OTPs in Quincy, Wellfleet, and Worcester, and we have 2 more in the pipeline in Springfield and Boston. And the majority of penal facilities across the Commonwealth, as Dr. Pody said, now offer access MOUD either directly or through the use of a community-based OTP. So this is pretty fantastic. When I started here almost 5 years ago, this was not the case, and we're working on access. So over time, the OTPs have grown. In July 2012, there were 32 OTPs with a total census of 15,000. In September 2023, as I just stated, there's 55 with a total of 24,000. Again, we saw 2,000 new admissions during COVID-19, and we really owe that to the increased flexibility that people were able to get methadone. All right. So in that survey of the OTP clients to examine patient satisfaction during the COVID-19 pandemic, we surveyed 53 OTPs were surveyed, and 4,567 surveys were used in the analysis. And respondents were mostly younger, white, both males and females were equally represented. They were engaged in treatment for a variety of times and chose their programs for a variety of reasons. So what did we learn? 77% of those patients were satisfied with the services they received during the pandemic. And patients reported successes with take-homes and with telehealth. So for take-homes, 85% of patients reported wanting to receive their medication completely as take-homes and or as a combination of in-person and take-homes once the COVID pandemic ended. There was an increase of 27% to 52% of patients receiving take-homes for at least 7 days in the month. Telehealth. So this is another pivotal moment in our world. Many patients who received telehealth services reported having easier access, could make appointments when they wanted to. And 81% of those patients reported wanting to receive counseling services, all by telehealth or a combination of in-person and telehealth once the COVID pandemic ended. The rate of satisfaction was higher among patients who received telehealth services compared to those patients who reported not receiving telehealth services. So the flexibilities just worked. So we saw a high uptake again of the telehealth and the take-homes. We had better engagement in treatment. We had increased client satisfaction. And we also, this is really important, we had 0 overdose deaths reported to us from methadone during the pandemic. So that is huge. So as I said at the beginning, we had this opportunity for a pilot project in Massachusetts during COVID to do all of the things that we were never allowed to do, or that was going way too slowly. So in an effort to continue this progress, the state has supported expanded access to methadone through mobile units, medication units, and alternative service delivery. The DEA has permitted registrants to add a mobile component to existing registration, has enabled both mobile and medication units to include collecting samples of drug testing, dispensing take-homes, and conducting intake assessments, initiating medications, and providing counseling. So this has allowed us to add new mobile units in Worcester and Wellfleet, where people would have to drive from the Outer Cape all the way down 2-3 hours to Hyannis. And as I said, there's 2 more in the pipeline, Springfield and Boston. We're also committed to ensuring the delivery of methadone to places like skilled nursing facilities and penal facilities. And we continue to advocate on a national level for more flexibilities to expand delivery to places like low threshold housing or places where the patients are, and not having to have them come to us. So looking to the future. So we are seeking to fund innovative models to help with direct admissions and transitions from non-OTPs like emergency departments, skilled nursing facilities, and ATS facilities. In emergency departments, we will be funding an addiction consult service teams that will work within the full hospital service systems and bridge clinics. The procurement was posted in spring, and our award making is in progress. We hoped for 3 applications. We got 16. We're hoping to fund 1 in every single region to make this work. So in skilled nursing facilities, we're working with colleagues in the Bureau of Healthcare Safety and Quality to ensure that patients residing in SIFs get access to methadone treatment. I hear this all the time. We're like, we don't know how to do methadone. I'm like, I'm pretty sure everybody in there's on palliative care or hospice. I'm pretty sure you know how to give out methadone. So, but that's their argument. We heard yesterday too that the pharmacies might not have methadone if we give it at pharmacies. Yeah, you do. You give it out all the time for people, as long as your diagnosis is not addiction. So since updating our regulations to require ATS in all levels of care to provide all forms of MUD, we've also been providing technical assistance to the ATSs to assist with induction and maintenance methadone dosing and stepping down to community health services. All right. So we still have much to learn from our counterparts in Canada, Australia, and the UK, right? Where in each of these countries, and the countries that Miriam just showed, right? Oh, I just lost my notes. That's all right. Let's go down. We have much to learn, right? From our counterparts. So we're just gonna stay with that. I'm sure I have something profound to say. So, but clearly I can't remember it without looking at my notes. All right, here we go. I know. Good thing I talk fast. All right. Methadone treatment for OUD in Australia has been provided through community pharmacies since 1985, and pharmacies are now the most common dosing site in the country. In Canada, stabilized patients can see their prescribing physicians only a few times a month, allowing physicians to have more availability to treat additional patients. In the US, one trial of methadone dispensing in a community pharmacy in North Carolina showed us efficacy. There was zero evidence of tampering and diversion of the methadone. Regular adherence to psychosocial counseling was adhered to. There was no positive urine screens for illicit opiate use and no study-related adverse events. And the participants in the study were also satisfied with the pharmacy access and the quality of treatment. So I hope, and when I first met Ruth 5 years ago, I told her my little dreams to blow up methadone in Section 35 and keep my job. So we'll see about that. I envision a system where there's a provision of individualized treatment regardless of which medication someone receives and regardless of where that individual seeks care. The future state does not eliminate OTPs, but ensures that they remain a place for structured patient-centered care and are relied upon for their content expertise. But it is not necessary to expand access to methadone and treat it like, but it is necessary to expand access to methadone and to treat it like any other medication, including ensuring it is available within a pharmacy. While this requires federal changes, BSAS is seeking partners and opportunities to pilot methadone in pharmacies. This is one of the things I like to just end on, is that when people say it's not that big of a deal to go to a clinic, and I think I have a car, I'm loved, I have food, I'm not beaten, my kids are cared for, and I couldn't get to a methadone clinic every day. I would fail out, right? And that we make the most marginalized, the most complex medical care get on a bus every day with their kids and or leave them at home, and risk DCF to go get their medication that is life-saving. So thank you guys for tolerating the technical difficulties, my reading really quickly, and I'm really grateful to be here today. Thank you.